No, Doctor.
Hello and welcome everyone for this live webinar show by Glaucoma Society of India. And this is Dr. Satyan. Today we have our two honorable past presidents, Dr. Vinay Nangia and Dr. Lingam Vijaya, both of them who has done an exemplary work in the field of glaucoma. Before they give their presidential talks, I would like to welcome our panelists, Dr. Alakesh, Dr. Roni, and Dr. Sachin for the panelists today. And before they start their talks, may I request Dr. Alakesh and Roni to introduce our today's presidents, past presidents. Over to you, Alakesh, first. Thank you.
Thank you, sir. It is indeed a matter of great honor for me to introduce Dr. Vinay Nangia, sir. To all the participants of this webinar, I don't believe he needs an introduction, actually. He has done exemplary work in the field of glaucoma, both nationally and internationally. Dr. Vinay Nangia, sir, is the chairman of the Suraj Eye Institute in Nagpur and the former president of the GSI. He trained at Shankar Netravaya, Chennai, at Manchester Royal Eye Hospital in the UK, and at the Harvard University in Boston, USA, in glaucoma and also in retina. Sir has been the chief investigator of the Central India Eye and Medical Study. His institute has affiliations with Global Burden of Diseases Vision Loss Expert Group, Heidelberg University, and the Asian Eye Epidemiology Consortium. Sir has more than 200 publications in peer-reviewed international journals. So,
Thank you, Dr. Alakesh, for introducing our distinguished speaker today, Dr. Vinay Nangia ji. May I request Dr. Roni to introduce Madam, Dr. Lingam Vijaya.
Thank you, Satyan, for giving me the opportunity to introduce Madam. It's indeed a pleasure to speak a little bit about her. Even though her current role is as distinguished senior consultant at Shankar Netravaya, she is better known for the 20 years where she headed and transformed the department, training over 100 glaucoma fellows who practice all across the world today. She's a member of the Board of Governors of the World Glaucoma Association and the Asia Pacific Glaucoma Society, and currently chairs the World Glaucoma Association Global Outreach Program. She's also a member of the prestigious Glaucoma Research Society, and as is obvious with this webinar, a past president of the Glaucoma Society of India. She has received numerous honors and achievements award from the AO and APO, and multiple publication awards from the IGO2. She was a principal investigator for the Chennai glaucoma study and the Chennai eye disease incidence study. She's extensively published and highly cited, and has actually delivered more than 10 orations. And more than all that, she's an excellent clinician. She's a great boss and a great teacher, and it's actually a pleasure to be able to introduce her.
Thank you, Roni. Thank you so much for introducing Madam. And we thank both our past presidents, and we are just waiting to hear from them. Over to you, Dr. Vinay ji. I think it is the correct time that we have in this World Glaucoma Week. We are going to just listen to our Dr. Vinay Nangia on the blindness in glaucoma. Over to you, Dr. Vinay. Yeah, we can see the slide. I'm not sure whether your audio is on.
Sorry. Yeah. Is my audio on now?
Yeah.
Okay.
Now it is on. Yeah. Thank you so much.
Thank you. Yeah. Thank you, Dr. Satyan and the Glaucoma Society of India for allowing me to give this talk. And I'm going to talk about blindness in glaucoma. And this talk is largely based on a paper that came out on global estimates on the number of people blind or visually impaired by glaucoma. And there was a meta-analysis that was done from 2000 to 2020, and I happen to be part of the group that published this. And then, of course, I would take you to something that is more relevant to India. Sorry, my slide is not changing. I have no idea what to do actually.
Yeah, down you will see the arrow. Come down to your left corner.
Just click your mouse pad.
Yeah, it's the mouse. I'm on a laptop actually. I'm just handing the mouse pad. I got it. Okay, thank you. So I just needed to click on the mouse. So, introducing glaucoma as a public health challenge. In 2013, it was estimated that there were about 64 million people affected globally. And this was projected to reach about 112 million by 2040. And glaucoma ranked as the second leading cause of blindness globally in 2020 after cataract. And it ranked as the fourth leading cause of moderate to severe visual impairment globally in 2020. And glaucoma is therefore the most common cause of irreversible blindness. So in this study, there was a systematic review and meta-analysis of published and the gray literature. Data from the Global Vision Database included all population-based studies that were published during this time period, and including the rapid assessment of avoidable blindness studies. We also had data from US National Health and Nutrition Examination Survey and WHO study on global aging and adult health. So when we define vision loss, it's basically based on the WHO criteria. And so moderate vision loss is a visual acuity of between 660 to less than 618. And severe vision loss is visual acuity of 360 to less than 660. Blindness is visual acuity less than 360. And perimetric blindness, according to the WHO criteria, is a visual field of less than 10 degrees around central fixation. And it's important to mention that the data regarding perimetric blindness is a little bit scarce in most of the surveys. So globally in 2020, there were 3.61 million people blind due to glaucoma. And this represented roughly more than 8% of all blindness worldwide. And of these, 1.89 million were males and 1.72 million were females. And globally in 2020, 4.14 million people had moderate to severe visual impairment due to glaucoma. And this accounts for about 1.41% of all moderate to severe visual impairment globally. And it was estimated that about 2 million males and a little bit more females at about 2.14 million had glaucoma-related moderate to severe visual impairment. So blindness prevalence surveys often assign the most treatable disease, let's say cataract as the primary cause. So if someone has cataract, we may miss out glaucoma and assign that patient as being blind or visually impaired largely because of cataract. And lack of visual field data in population-based surveys often leads to misclassification of perimetrically blind individuals. And I'll come to that a little bit later on. And the definition of moderate to severe visual impairment also does not include perimetric criteria. So in terms of the regional variations in blindness, we looked at the proportion and prevalence in 2020. And the highest proportion of blindness from glaucoma was in high-income countries at about 26.12% of all blindness. And North Africa and Middle East, it was about 14.98%. And then it tended to decrease a little bit. And the highest age standardized prevalence in those above the age of 50 years was in sub-Saharan Africa at 0.66%. And you can see the pie chart on the right side, which tells you that the high income countries, had the largest proportion of blindness was due to glaucoma at 26.12. And that was followed by Africa and Middle East, and then by Central Eastern Europe and Central Asia. When we looked at the variations in visual impairment, we found that the highest percentage was in Latin American and Caribbean region at about 2.04% of all moderate to severe visual impairment. So we're already getting a sense that the proportion of moderate to severe visual impairment due to glaucoma is much less than the proportion of blindness due to glaucoma. And of course, there's a lot of debate around this. And the highest age standardized prevalence in those above the age of 50 years was also in sub-Saharan Africa. So sub-Saharan Africa really is a hotspot for prevalence of blindness and visual impairment for glaucoma, and that's something that everyone needs to be aware of actually. When we look at the number of people blind with moderate to severe visual impairment in 2020, then we find that you can see the blue bar diagram on the left-hand side. We find that in the high income region has about 7.86 lakhs people as blind from glaucoma, and South Asia is calculated to have about 5.79 people blind from glaucoma. And in terms of moderate to severe visual impairment, we have 1.16 million people blind, and they are in Southeast Asia, and Southeast Asia, East Asia, and Oceania is followed by South Asia as having the largest number of people that have a moderate to severe visual impairment. When we look at the temporal trends from 2000 to 2020, then we find that there are global and regional reductions in age standardized blindness actually. So there's a global decrease in age standardized prevalence of glaucoma-related blindness in those aged 50 years and above. And there's a reduction by about 26% in the males and 21% in the females. Large reductions in age standardized prevalence were seen in Southeast Asia, East Asia, and Oceania, followed by South Asia. So South Asia is important for all of us because India is a large part of South Asia, actually. And we found, however, that there was a global and regional increase in age standardized prevalence in moderate to severe visual impairment. So males showed an increase of 3.7%, and females showed an increase of 7.3% of moderate to severe visual impairment when we looked at the temporal trend from 2000 to 2020. And so this is something that we really need to worry about. And of course, that in age standardized prevalence, somehow Southeast Asia, East Asia, and Oceania, they stand out because they saw an increase of almost 18.43%. When we take a look at the sex differences in glaucoma blindness by region, we found that consistently higher age standardized prevalence was seen in males across all regions. So it was most pronounced in North Africa and Middle East, and also then in sub-Saharan Africa, where males had a age standardized prevalence of 0.79% and females at 0.56%. And it's also important to note that blindness reduction over this period of time was greater in males than females globally, and moderate to severe visual impairment increase was greater in females than males globally. So there's a complex interplay that's taking place of biological, healthcare access, and social factors. And with so much data, it's always sometimes difficult to figure out what are the exact causes that are taking place in each region that define these changes that we see actually. When we take a look at the global glaucoma-related vision loss by gender, then we find that roughly about 1.89 million males are blind, and 1.72 million females. And I've mentioned this before at the start of the talk that for moderate to severe visual impairment, the females show 2.14 million in number, and the males are a little less at 2 million actually. So what are the possible explanations for the trends? Despite reduction in age standardized prevalence, absolute numbers increased by 41.03%. That is increase in the absolute number of people blind from glaucoma. And we find that from 2.56 million in 2000 to 3.61 million in 2020 were blind from glaucoma. And there's a 91% increase in the absolute number of people with moderate to severe visual impairment from glaucoma, from approximately 2.16 million in 2000 to 4.14 million in 2020. And of course, the population grew from 6.1 billion in 2000 to 7.8 billion in 2020. And the proportion of older adults more than 50 years of age increased, and the number of people aged 65 plus years worldwide grew from 420 million in 2000 to over 700 million in 2020. And all this is extremely important for a country like India, where very shortly we are going to transition into an aging society, and we will have the same kind of numbers to speak about actually. So there are significant challenges in low and middle income countries. And so India is classified as a low to middle income country, actually. And so there's increasing pressure on healthcare resources. There's a longer asymptomatic phase in low middle income countries because not only because of primary open angle glaucoma, because we can't diagnose them, and we know that 90% of glaucoma stays undiagnosed. Approximately 35% of patients in low and middle income countries are blind at diagnosis. I wish that we could, study this a little bit more. And there is a higher prevalence in sub-Saharan Africa, partly due to lack of access to treatment and partly because of the ethnicity. So the study has weaknesses and strengths, and the weaknesses are that many countries lack data across the entire time period or had only subnational data. And that is very common when you do studies in a small region, and then you have to extrapolate it to the rest of the country. And that happens in most countries. And most studies did not disaggregate findings by glaucoma subtype. So if you're doing a RAP study, sometimes it's very hard to find data that will disaggregate types of glaucoma. And studies typically report one principal cause of vision loss. So if one feels that the vision loss is because of cataract, one might therefore underscore the impact of glaucoma or something else, actually. And the strengths, of course, are that there's a huge amount of data that was accessed, and that we were able to do a trend analysis, and that that there were large uncertainty intervals that were taken into consideration. And of course, a lot of people were involved, and all that helped, actually. So this is a study that Ronnie and Vijaya published in 2022 in Eye, and I thought is very pertinent also because of the topic. And the aim was to estimate the risk of blindness with primary angle closure glaucoma compared to primary open angle glaucoma using population-based studies. And they did a meta-analysis of 23 population-based studies, also between 2000 and 2020, reporting prevalence and blindness rates for both, actually. And they found, and this is very important, I will come to it shortly again, that primary angle closure disease and glaucoma is significantly more likely to be associated with blindness compared to primary open angle glaucoma. And the cumulative risk ratio of blindness in PACG to POAG was 2.39. This means the risk of blindness is approximately 2.4 times higher in PACG compared to POAG across the studies analyzed. And all of us as clinicians, we sense that this is more than true, actually. And this finding held true despite variations in blindness definitions and criteria for angle closure used across studies. So in both rural and urban settings, PACG shows 2.5 to 3% higher blindness rates than POAG. And in rural population, the risk ratio was 2.37. And in the urban population, the risk ratio was 2.65. And the graph, explains the differences in the rural and urban settings. And the urban settings on the left side of the graph, and the rural findings on the right side. And this is of course very important, that the blindness, while the prevalence might be a little less in the rural community, but the blindness proportion is relatively high in both the settings. This is, I think, very important. That tells you about the basic nature of primary angle closure glaucoma. So this is part of the study that we did in Nagpur on 88 eyes, and you can see that the number of eyes that presented with less than 22 millimeters of mercury was relatively less, and that a large number of eyes presented with intraocular pressure of 22 to 30 millimeters of mercury, and also more than 30 millimeters of mercury. And that's very important, because that means that the average intraocular pressure in this group of subjects was almost 30 millimeters of mercury, plus minus 13.4 millimeters of mercury as standard deviation, with a range of 10 to 65 millimeters of mercury. And when we looked at the graph on the right-hand side, we find in terms of visual acuity, only 42 eyes had a visual acuity between 6.6 to 6.9, 14 between 6.12 to 6.18. And you can see that 6 eyes had counting fingers hand movement, 6 eyes PLPR, and 3 eyes no PL. So when you do a population-based study, this is not what you find. You find that the average visual acuity, best corrected visual acuity, tends to be around 6.9. So when you find something like that, it tells you really that, diagnosing and treating primary angle closure glaucoma requires efforts in order to save blindness, which comes rather quick, actually. When we take a look at the public health translation in terms of the prevalence, we find this data is based on the population of India when it was 1.21 billion, we're now 1.4 billion. But the prevalence at 3.45% in those above the age of 40 plus years was 11.27 million, and then above the age of 50 plus years was 9.79 million, and above the age of 60 plus years was 7.78 million. But what I'm trying to really say is that 90% of them are undiagnosed. I think that's really what is important. So if not more than 10% have been diagnosed or are aware that they have glaucoma, and that 60 to 70% of the glaucoma is in rural areas, almost all undiagnosed, that means that 90% of glaucoma subjects are potentially under threat of visual impairment and blindness, actually. And that's really a huge challenge that we have in a country like India. And in the Central India Eye and Medical Study, visual impairment from POAG was seen 31.5% and blindness 0.9%. But when we look at unilateral visual impairment, it was 37% and blindness in 10%, actually. Likewise, unilateral visual impairment in PACG was at 33%, but blindness was at 19%. Again, underscoring the fact that blindness from PACG is really very common, and we need to be aware of that, actually. So these are some indicators that tell us as to where India is in terms of economy, because economy has got a huge role to play in creating awareness and in diagnosing and treating glaucoma. So this tells you the GDP, the per capita income, the fertility rate, and the health expenditure. And all of them, including education, go to create what is known as, the socio-demographic index that classifies us as low income, middle income, or a high income region, actually. So India still belongs to the low middle socio-demographic index or middle socio-demographic index. And this appears to be an increasingly important indicator for healthcare in normal circumstances across the world, actually. So glaucoma remains a major global cause of blindness, and regional variations exist in the burden and trends of glaucoma-related vision loss. While glaucoma-related blindness has decreased globally, moderate to severe visual impairment has increased, and significant challenges remain in countries like India, and continued efforts in all directions are probably crucial. So by the time the vision is less than 618 in a glaucoma patient, the patient is only being considered to be visually impaired. The real life situation is completely different. When someone has less than 618 vision, all glaucoma specialists know that this patient has significant visual field loss that will inexorably lead to blindness. We need to take this into consideration as we define visual impairment and blindness in glaucoma. We face several challenges, and as I mentioned, undiagnosed glaucoma would mean blindness, and we are therefore stating that if 90% of glaucoma is undiagnosed, they have a very high likelihood of going blind. That's the current situation in our country. Looking for glaucoma is therefore important. For those who go blind from glaucoma before time, they need help for rehabilitation. And what is the relevance of a 10-degree visual field in one remaining eye in our rural patients? How far is it going to get them in life? Thank you very much for this opportunity.
Thank you so much for a wonderful presentation from Dr. Vinay Nangiaji. That was a great presentation, and it is really an eye-opener for every one of us. And it indicates how much of the work needs to be done for our own patients in India. So I think on this World Glaucoma Week, Awareness Week, we all probably take a pledge to whatever possible way that we can help our patients. I think we should go ahead and do it. May I request our next speaker, Elvija Madam, to share your slides and then give her presentation, and then we can have our panel discussion once Madam finishes her talk. Over to you, Madam. Thank you so much.
Thank you. Thank you very much, Sachin, for this kind invitation. Thanks, Ronnie, for your kind words. You're always kind to me. So my talk is going to be purely a kind of a clinical situations where tubes are used while doing some of the difficult glaucomas and also with the refractory glaucoma. So when you look at the management of the cataract and glaucoma, we have various options. We can just do only the cataract surgery alone, or nowadays we combine it with the mix, especially with the open angles most of the times. or we can combine with the trap, or we can combine with the tube. So the PSE and PSCS, the cataract surgery helps where the volume of the lens has been reduced and there will be widening of the angle. And whereas with the PSCG and POAG, the severity of the glaucoma dictates what kind of a surgery we should be doing. So even though the tubes are not commonly done, we do need help of the tubes and when we are doing certain cataracts. So in general, at least in our country, the practices are very widely variable. There is a varied opinion about tubes as a primary procedure with the cataract surgery, even though in the West, people do it. In our setup, it is still done for difficult cases where the conventional surgeries are likely to fail. In certain refractory glaucomas with the cataract, combining cataract with the tube is a preferred method. So I will be sharing some of the clinical conditions that we handle in our institute with the cataract and some of the refractory glaucomas where the tube has really made a difference in controlling the eye pressure. So this is one of the patients where there was a secondary glaucoma with a necrotizing scleritis and cataract, single-eyed man. If you see here, there is everywhere there is thinning of the sclera, and he needed cataract surgery. So a phaco with the intraocular lens was done. At the same time, a tube was inserted in the superior temporal quadrant. He remained stable for almost for the last 10 years with one drug, which is quite satisfying for the surgeon as well as for the patient because there is no other surgery is feasible in such a situation. And this is one of the patients of my colleague, Dr. Bhaskar, where in eye syndrome, we know very well the conventional surgery doesn't work. And we tend to do the AGV in such a situations. And AGV has developed encapsulation and at the same time also developed the cataract. So Dr. Bhaskar has done the phacoemulsification with intraocular lens implantation along with the revision of the AGV implant bleb. This is a small video that gives you the details of the procedure. So he is taking the superior rectus to stabilize the globe because the bleb is quite posterior and conjunctival incision near the anterior edge of the plate has been made. And once it is done, the thickened capsule, the tenon capsule is opened up and it was dissected. And he's using the 0.1 ml of 0.02 milligrams of mitomycin C into the bleb. So after injecting that, he went ahead and did the phacoemulsification. Surgery is the routine procedure. There is not much difficulty. So the lens is being implanted into the bag. So then what he did is he kind of irrigated the tube. You can see that here. He went in with the fine cannula and irrigated the tube and established the flow and closed the wound to avoid any possible leak. After that, so it was almost 15 minutes. The capsule is excised and removed. See how thick is the capsule here. You really need a sharp instrument to incise and remove the capsule. So gush of the fluid was noted. That was the aqueous from the bleb. Again, he reinforced the plate with a nylon suture and closed the conjunctiva in the conventional method. So it is one way of restoring the function. And this is a third case I will be talking about, a refractory childhood glaucoma. Child was born with an neonatal onset congenital glaucoma, had external trabeculotomy with a trabeculectomy in 2004 at a tertiary care center in central India. Later on, developed retinal detachment in 2018 and required multiple surgeries. Pressures were not under control, had diode ablation in the right eye in 21 and 22. He came to us for a second opinion. Vision was 1/60 in the right eye, hand movements in the left eye. Intraocular pressure was abnormal in both eyes, and both eyes view for the gonio was hazy. There was anterior insertion of the iris. There was corneal haze with the BSK, and there was cataract. Right eye showed advanced cupping. If you look at the axial length, it's 30 in the right eye and 31 in the left eye. The right eye is the seeing eye. And if you see the slit lamp picture, there was silicone oil everywhere. And the pupil is peaked. And so we plan to do an AGV with the cataract, because that is the only seeing eye, a young boy who is studying. So you have to be careful when we open the conjunctiva here, because there is so much of stretching. There were oil globules in the subconjunctival space that needs flushing out, and we anchored the plate in the usual way, 8 millimeters from the limbus, and you tuck the tube into the subconjunctival space. Then I went ahead with the cataract surgery. The challenge here is eye can be soft, the pupil won't dilate. You have to use the iris hooks. So what happens when we use the iris hooks? The antechamber is so deep, the angulation of the iris hooks becomes a little difficult. You may have to use a second instrument to bring the iris hooks onto the iris. Stain the capsule because the view is difficult, and did the capsulotomy in the usual way. So you always wonder whether the lens is stable or not. So you have to make sure there is no dehiscence. There are no issues with the lens. You see how difficult the view is. I have to use the maximum autoflux to visualize the capsule. In spite of the good viscoelastic, it was difficult to insert the lens because of the softness of the eye. Once that is done, and I try to close the wound because the eye is likely to be soft. Inserting the tube through the sulcus, because the cornea is likely to have problems in these eyes because of the multiple surgeries. So you insert the tube through the sulcus, and being a very prominent eye, even occluded partially the lumina of it, then fix the tube and use the corneal graft to cover the tube and close the conjunctiva. And in the post-operative period, his vision improved, and his pressure was 22. He needed a dorzolamide with a timolol 2 times a day to control the pressure. He had advanced cupping, and he seems to be stable. So it is one of the challenging cases where the tube and cataract help the patient to regain some amount of the vision. It is again post-PK glaucoma with the total cataract. And this was a 38-year-old male, a defense bomb diffuser, blast injury while diffusing the bomb, and the right eye had a perforated cornea, left eye went into thysis bulbi. And the right eye had a Tenon's patch graft, and he is on 2 AGMs. And right eye also had a tectonic PK 5 months post Tenon's patch graft. He presented in the glaucoma department with high pressures and total cataract with extensive synechiae. He was offered to go through the phacoemulsification with intraocular lens implantation and inserting the AGV with the tube insertion into the sulcus. The challenges are many. specular count showed a low specular count. There was a significant astigmatism, but we are not keen to offer any of the toric lenses because of the difficulties we will be having in doing the surgery in these patients. And also, it is not easy to use which keratometry for the biometry. We took the help of the Topake to have a appropriate biometry calculation. And my colleague, Dr. Parivadini, has taken up this case, and you can see that after inserting the tube, and after fixing the plate, she went ahead and tried to do the cataract. And every step, it is a tough, because some of the wounds were, sutures were giving way. And after staining and using the good viscoelastic and doing the rexis is a challenge. She has to constantly bring it back to the position to complete the rexis. So this was followed by the cataract removal, and she also has to reinforce some of the sutures to make the wound tight. The lens is placed in the bag. Tube is trimmed and inserted into the sulcus. That is the key here. You cannot keep the tube into the antechamber in a situation like this. And usual way that the tube is fixed and the patch graft is the corneal patch graft is placed and secured, and conjunctiva is closed. So fortunately, he did well, and post-operatively, this is the clear graft and tube in the sulcus. IOP is maintained with a 1 AGM. This is a 7-month follow-up. Even though there is significant astigmatism, he was able to use the glasses and has a good vision in that eye. But the specular count has showed reduction. Only with the time we will know what we will be facing. So moving on to the few refractory glaucomas, I think I have, okay. So this is one of the difficult refractory glaucomas where the tube as a primary procedure has really saved us. 22-year-old female referred to us for surgical management of the advanced glaucoma. She lost left eye following an injury, and complained of defective vision almost for 8 years. She was on maximum medical treatment and diagnosed to have glaucoma for a few years back, and a known case of Ehlers-Danlos for 20 years, and also gives a history of status post PDA closure and subaortic membrane dissection in 2000. Family history, nothing significant. Intraocular pressure was 36, very thin corneas, had equatorial cephaloma, had a clear lens, and the pressure was very high. And this is the Optos picture that shows that quite tessellated fundus with the extensive chorioretinal atrophy and advanced glaucomatous cupping. These are the visual fields. So what we offered is we diagnosed as a open angle glaucoma with a pathological myopia, offered to do an AGV implantation because of the staphylomas what she was having. And inferior nasal site was decided. We also wanted to use the fibrin glue to avoid the number of the bites we take on that stretched out cornea. You can see the extensive thinning what you have noted. And this is the inferior nasal quadrant. So undermining is important here to place the tube well. And you can see here trying to place the tube 8 millimeters from the limbus. Tube was able to be, there was no difficulty in doing that. The difficulty what we had was in inserting the tube. So when we made a small track that is routinely done, trying to push the needle, you can see there is iris here. They're like a peripheral antisynicate. And try to push the tube into the place, not unable to do it. I have to change the direction and then insert the tube. In inserting the tube, you can notice here there is tucking of the iris to the tube. So what I thought, maybe I should trim the tube a little more to avoid that. I took it out and shortened the tube and made little longer bevel, but still there is tucking. So what I decided to do was, took it out and made a long bevel. So I kind of de-roofed the part of the tube so that it will not get obstructed by the iris. The tube is inserted. It seems to be okay. What is important to notice here, even though it is a pathological myopia, antechamber was not as deep as anticipated. So use the glue to cover the, keep the graft. So once it is in its place, the conjunctiva is closed. Even though if we use the close the conjunctiva with the glue, using the sutures also helps so that post-operatively you will not have surprises where it gives way. So had in the first post-operative day, had a flat antechamber. Intraocular pressure was high, but fortunately responded with the dilatation and systemic acetazolamide, and treated him with the anti-glaucoma medication and topical steroids and atropine. And post-op day 2, antechamber was deep, but we noticed hemorrhagic for adults that needed systemic medication with atropine and dorzolamide. And this is the post-operative periods. The period where the pressure is under control, but there is some tucking. So AGV implant was successful. We would not have done the diode CPCR trabectedin with the metamycin C. In the interest of the time, I think I will be avoiding a couple of cases. And I will conclude my talk with the tips for a tricky situation. So whenever vitrectomy has been done, inserting the tube through the pars plana is a very good option because vitreous has been removed. Take 3.5 millimeters and insert the tube into the pars plana. And use the light pipe AC maintainer whenever you anticipate possible hypotony. So that keeps the eyeball firm, and by inserting the tube, also completing the surgery becomes easier. And whenever possible, we insert the tube through the sulcus, like in pseudophakic eyes. If there is a pre-existing PI, we can even bring out the tip of the tube after inserting into the sulcus through the PA like this, so that chances of getting blocked by the iris is very low. At the same time, you can visualize what is happening to the tube tip. So you insert the needle into the sulcus towards the PA, and the tube is being inserted into the sulcus. Then you can see here coming into the antechamber and resting on the iris. These are the few tips, and the light pipes helps in using the inserting the tube in any situation like this. So you can visualize the antechamber here. So the tube can be inserted away from the cornea because of the visibility of the anterior chamber by use of the light pipe. So these are some of the tips, and these are some of the thoughts. Just wanted to share with you what we do in managing refractory glaucomas in our clinic. Thank you very much.
Thank you, madam. Thank you for wonderful talk and wonderful videos. All that were very tough patients.
Thanks. Thank you.
Thank you so much, madam. May I request all the panelists to have the discussion and then Dr. Roni, Alakesh.
So we had two very interesting talks, and I actually have a couple of questions for Dr. Vinay Nangia. So the data that you presented, actually the South Asian visual impairment came down over time.
Yes.
And what do you think are the reasons for this, considering that the other...
So, so this is what the data threw up actually, And so there were a lot of surprises when you go through it, and sometimes you find it a little bit hard to explain. Now, really, the issue is when you're looking at, this is what I alluded to, that when you have moderate to severe visual impairment, that's really, that means that it's really less than 10 degrees actually. There's really nothing remaining, because the fixation is gone. You're looking at 618, you're looking at 636, but you're still calling it moderate to severe visual impairment, and it's a area that has no definition actually, in relation to glaucoma actually. So so that's a very pertinent question, and that I think that there are no clear-cut answers to that, Ronnie, and I'm sure you understand that as well as I do actually.
I just wondered whether you had any...
No, I don't actually, because on one hand the blindness levels have gone down, and the moderate to severe visual impairment has increased. Now, how do you reconcile that in a situation of central visual field loss with the vision being 618 or 624 or 636? How do you reconcile that actually?
Yes. Yeah, I mean, that's one of the issues when you're doing data mining, that sometimes you don't have the granularity of data to be able to make.
Yes. So, I'm glad you use the term granularity. That's what, all epidemiology in ophthalmology is really struggling to get granular data, because studies like yours or several such studies like yours, they're not being performed at the same pace actually. And in a sense, we're not able to keep pace with what's happening today. We kept pace with what was happening 10, 15 and 20 years back, but we really don't know what's happening now, and we don't have granular data with with the best of equipment and things like that. So this is a pause sort of in epidemiology that all of us are going through actually,
globally.
Yeah.
Dr. Vinay Nangi, sir, I just wanted to ask you one thing, that what the data throws up. One part I found interesting, that in many of those data, it was like, for example, the higher socioeconomic group. So in them, the prevalence did not decrease, and the male-female ratio is more or less equal, sir. So, I mean, would you, with your gamut of knowledge, think that this points towards the fact that the lifestyle diseases having a greater prevalence in them is perhaps a reason for this fact that we are seeing this sort of data thrown up by the studies, sir?
So I'm glad you asked that, and I've just opened up that slide on the computer where the highest proportion of blindness in high-income countries, roughly about 26% of all blindness, is because of glaucoma actually. And that's because cataract and uncorrected refractive errors are largely taken care of, so they're struggling with glaucoma and age-related macular degeneration. And so that's classically what we should expect in high-income countries. As far as the male and female blindness, visual impairment from glaucoma not being extremely difficult, so that's largely because the cultural parameters and socioeconomic parameters are such that everyone has access. As in several European countries, they will reach out to their homes and give them a bus and bring them to the clinic and make sure that someone goes and puts drops in their eyes. So those are things that really have helped them in that sense actually. And of course the fact that it's an aging society, something, as I said, we need to be worried about, because initially it was thought that the that the population is going to decrease from 2050 onwards, but we seem to have reached that stage, roughly 25 years ahead of time. So we are anticipating a population degrowth to take place in India, and that's effectively means that we're going to grow old very rapidly. Actually, that's what it really means. So what we're seeing in the high income regions in terms of blindness and visual impairment is what is our future if our economy increases, if our economy increases, actually.
Thank you, sir. Vijay ma'am, could I just ask you one question, ma'am? Is that like for the encapsulated AGV, ma'am, what is the what would you say is the exact area of resection of the fiber sheet that you would advocate? Like Dr. Bhaskaran had actually cut the area over just the valve mechanism. Do you feel that is enough, ma'am, or would you say that we should go a little bit more backwards? I mean, does it really help out that way, or a limited resection
Okay.
works, ma'am?
He did dissect the quite significant piece of encapsulated bleb over the plate.
Yes, ma'am.
So that is, he has removed it over the plate and then sutured it back and restored the flow through the tube. So whether it's fortunately it did work for that few months of time. We don't know how it is going to behave, because we know very well eye syndrome, it is not very easy to manage. So basically to say that when we're doing the cataract, because the the pressures are not under control, so he has kind of added this procedure to control the pressure.
Thank you, ma'am.
Yeah, madam, one question. Superb and very difficult cases as usual from you. But about this encapsulated blebs, what is the incidence in your institute of encapsulation of AGVs? Because we are finding that the incidence is quite high. And secondly, how well has this capsule removal helped over the long term in terms of eventual success?
Okay. So if you look at the encapsulation between the valved and non-valved, the non-valved has a very low incidence, whereas the valved has a higher incidence. So maybe almost maybe close to 10 years, we changed our techniques. One of the reasons why the encapsulation happens is in the immediate postoperative period, there is a large volume of the gush of the aqueous from the antechamber into the plate area that brings in a lot of fibrogenic factors, and that is responsible for the encapsulation to happen. So how, if you can reduce that gush of aqueous coming to the antechamber by aqueous suppressants, starting them in the immediate postoperative period, and our rates for the encapsulation has come down dramatically. Still, we do see the hypertensive phase, and we continue to use the medication. We don't have a published data on this. We also use a simple measure of the digital massage that helps flow through the tube into the bleb area and to reduce the compactness of the capsule and reduce the chances of the hypertensive phase. So these are the measures we started using that has reduced our hypertensive phase.
And how long do you recommend the digital massage, madam? Because we also noted a similar fact that even months after the surgery, the digital massage does help in, for increasing the porosity of the capsule. So do you advise maybe the patient should continue?
Till it gets stabilized, the pressure control should be there with the medication alone, not with the digital massage. So we don't have, as I said, we have no published data. We don't have the data to support our statement.
And one more point that you raised about the lesser hypertensive phase in the non-valved implant versus the valved implant. So in a situation wherein you can have a choice between the two, like for example, if you have some leeway or time to reduce the IOP, or you can wait for a month's time for the IOP to come down and is controlled well on medications, but still you want to go in for a surgery. In that case, would you prefer non-valved as your first implant rather than valve?
Yeah, I would, if you look at anywhere worldwide, if you look at the data, yeah, the non-valve gives a low pressure with a high complication rate of hypertony related. Whereas the valve gives not as low as the non-valve, but the number of complications are very less. So you have to choose between the two, which one you want. And since we are used to the valve one and our hypertensive problems have come down dramatically with the use of the aqueous suppressants, we still continuing with the valve. But yes, we also use the non-valve depending upon the case scenario. But you always should remember that if you want a low pressure, you can go for the non-valve, but anticipate higher complication rate. And if you want pressures are okay, maintained with the medication, don't want to have any complications, valve is the answer.
And one question.
But I also want to emphasize that not that all non-valve will be successful 100% of time. In the long run, if you look at the success rates, they behave more or less the same over a period of time.
Okay, madam. And one question, especially for you, because you will be only privy to this particular information, is about the Paul's implant. Since it is being launched now, I think in the next few months in India, I think in the AIOS. What are your experiences? I've seen a couple of cases which were done by you, beautifully by you, and they were very well controlled, nice blebs, thin walled. So, do you think that it is having a different kind of a behavior as compared to the other two?
I think the major difference is the size of the tube. Since the lumen is small and you can insert through the 26 gauge needle, and the leak around the entry also is less, but still we do occlude the lumen. So our experience is very, very small. We had 4 patients. All 4 are very, very difficult glaucomas, and 4 have done well. So there is, and if you look at the data from abroad, they have publications. I don't have the information offhand. Even 3-year publication, they have published it. And it does give fairly good control of the intraocular pressure with less complications in comparison to the other non-valve blebs. Again, caveat is not that it will give you 100% success over a period of time. It has it behaves like other tubes. With the period, the success rate comes down.
Just one last question to you, Vijay ma'am. Is this that the aqueous suppressions that you are now using in cases of AGVs to avoid the hypertensive phase and perhaps try to prevent the fibrosis? What is your drug of choice, and for what measure of time do you normally?
Most of the time, they need a combination medication. Most it is dorzolamide with the timolol is the most commonly used, because unless there is some contraindication for dorzolamide, like any corneal issues, then you go for the brimonidine with the timolol.
Thank you, ma'am.
Is Satyan missing? You have to call Satyan.
He's there.
I think he might have gone for the AOS.
All right. So, Ronnie and Alok, you can. Oh, hi. Welcome.
So in absence
Just
of
in time.
I just formalize and thank all the panelists and the esteemed president speakers for giving us a lot of insight into the problem of glaucoma. Thank you, Dr. Vinay. Thank you, madam. And thank you all the panelists. And tomorrow again, we have a session. So we look forward to logging in at 8 o'clock tomorrow evening. Thank you very much.
Thank you.
Thank you. Thank you.
Thank you for the opportunity. Thanks.
A great night, actually. Bye-bye.
Thank you. Bye.